I love to see all of our friends from everywhere. Welcome, everyone. We are so happy to have you joining us today. This is part 2 of this series. We talked with Amy O'Rourke a couple of weeks ago about home care options. Today, we're going to be talking about long-term care facility options, kind of explaining what some of the different terms mean and what the kind of care you receive in those facilities are, how they're paid for, and that type of thing. But before we get started, I just have a couple of bits of housekeeping. First of all, if you would go to the bottom of your screen and open up your chat box, and that's where we want you to put your questions today. We will ask them as we go. And also, as I always ask, I just like to know where everyone's joining us from. So just give us a shout out and let us know where you're coming to us from. And then we're going to get started. So I'm Anissa with PMD Alliance, and with me today is Amy O'Rourke. Some of you may have been on the first program, and she's been on several in the past with us. She is a certified care manager. She's a board member of the Aging Life Care Association, the founder of the Cameron Group, which is Aging Life Care Services in Orlando. She's also author of the book, The Fragile Years, Proven Strategies for the Care of Aging Loved Ones. She has many, many years of experience as a care manager, and was even I think you were like a nursing home
administrator.
That's the word I'm looking for. Thank you. Need a little help there. So she definitely has a lot of expertise in this area. But before we launch in the discussion about long-term care options and what level of care means, if you were joining us the last time, we talked a bit about different types of care that you would get at home, from what a home care nurse or home health is versus home care, personal care, those type of things, adult day facilities, and home hospice and things like that. We had a really good question that came in right after the program that I think is a relevant thing to bring up before we get started. And that is if you have someone at home and you're bringing in different types of equipment, such as hospital beds, Hoyer lifts, wheelchairs, bedside commodes, those types of DME, what we call durable medical equipment that can help care be a little bit easier. How are those paid for? What does Medicare cover? What is an out-of-pocket expense? And so I just want to spend just a real quick minute, if we can, Amy, and go back to that topic, and then we'll get into today's topic.
So, and it's great to be here again. This really tops the list as one of my favorite groups to talk to. You guys are engaged and pay attention, and your hearts are in the right place. So I'm very, very happy to see you again. So Medicare will pay for equipment. They'll pay for a hospital bed. They'll pay for a wheelchair. They'll pay for a shower chair. They'll pay for an over the commode chair. What they have is, and I can't go through every single piece of equipment and tell you what the time period between, say, for example, they'll cover a wheelchair, but then you wait 5 years for your next one. So there's, you get one hospital bed, but then there's a period of time we have to wait for the next one. You can get those lift chairs, and Medicare won't pay for the whole lift chair, but they'll pay for the motor. So really the easiest way to think, and they'll cover a shower chair, but if you get a shower chair, usually those double as an over the toilet seat. So they'll only pay for one. So what I like to think about is, what do I need? And then the durable medical equipment will bill Medicare. So you'll just double check with them and say, these are the things that I'm needing, or a social worker in the hospital or the skilled nursing facility, this is their job. So, you don't have to pay somebody to do it. If they're in a facility, the facility social workers should know the answer to this. Grab bars are generally not covered by Medicare, interestingly enough. But the durable medical equipment company that is working with the facility that you're working with, or with the home care company that you're working with, will be able to tell you what's going to be covered and what percentage and what the period of time in between, how many years you have to wait before you get a new whatever it is you're ordering.
Right. So, and the question was like, if they're at home, how do you find out like what's covered? So would you recommend, like, if you call a specific company that might have all of those, or say, okay, here's the list of things I need. And isn't it true, like if you get like a wheelchair and you bill Medicare for that, they're not also going to pay for a walker, because those are two mobility related devices. So you want to go with the thing that's most expensive and have Medicare cover that and then pay out of pocket.
That's right.
And they're asking, is that Medicare B?
Medicare B.
Yes, right.
Medicare B. Medicare A is hospitalization. Medicare B is like everything else. And the other thing is, I think that in many cities across the country, Orlando for sure, has secondhand medical supply stores. You know, there's lots of wheelchairs floating out around there, and there's lots of walkers floating out around there. So that you would need to pay a lot of money for any piece of equipment now and not be able to find it secondhand or on Amazon. You should be able to find what you need. So yeah, we must remember many live in rural America. I do see that, and I do know that, and that's why I like ordering online. And you can find some online providers that you might be able to find something reasonably priced. Not that I'm selling Amazon or Walmart, because I don't, but the opportunities for equipment that are reasonably priced has seriously expanded. If you want something customized, I would be working with a physical therapist to see how much of the chair you could get covered, because somebody brought up they didn't buy the wheelchair that they wanted, and that could very well happen once you get into customization. That's often true. So,
and that's such a good point, because I have worked in the past with physical therapists that were able to do some extra documentation for justification for things. And it may not pay for 100% of it, but they might be able to get more coverage than, what you would expect, because a lot of times they want to pay for a manual. But if you have somebody that's just not even in the realm of possibility because of their mobility limitations, there may be some justifications that a therapist could make. Is that correct, Amy?
That's right. That's right. And keep in mind that these are medically ordered pieces of equipment. So you have to have a doctor's order also. So if you have medically necessary documentation, it makes for a better case to get Medicare coverage. Right.
And so, yes, so there's a question of, will Medicare pay for the basic and you pay for the balance? There is some of that too. Like right? I mean, you may have to pay parts of what you want if it's a little more maybe advanced than what they're saying you were medically justified for.
Right.
Okay. Well, thanks for adding in that conversation a little bit. I know that was a little bit off topic from today, but I just think it's important. And since we're talking about different types of level of care, this certainly fits into that. So that's the next thing is we talk about so many different acronyms. So we're going to be kind of breaking them down today, but level of care is one of them, or you might see written on documentation, LOC. So will you start us off first by explaining what that even means and what are the different types of level of care?
Yep. So before I talk about anything, I'd love for people to understand how care is measured and what care is measured. So the acronym ADL, Activities of Daily Living, ADLs. And those of us who are in the business, we say it really fast and we expect you to know and remember what ADLs are, because we hear ADLs all the time. Activities of daily living. And those are bathing, dressing, toileting, eating, walking. And all care is measured by your ADLs. How well do you bathe? How well do you easily to go to the bathroom? How do you eat? Now, once you are familiar with, bathing, dressing, toileting, walking, feeding, eating, then you move into the different housing environments, and then you have to understand the concept of dependence. Dependence, and the other concept is assistance. And is this subjective in the industry? Absolutely. I'll give you some guidelines. I remember when I was an assisted living administrator, and I walked by a room and I saw an aide providing, she helped her stand up. She dressed her completely. It was like she did everything for her. And we were assisted living. What she was providing was dependent care in an assisted living. We weren't regulated to provide what she was providing. And I walked in, I said, we need to have a conversation. And the aide had been doing this for her for a long time because she didn't want her to have to go to the nursing home. And she knew that if she got busted, she'd have to move to the nursing home. So I want you to understand that ADLs, and we'll use bathing just by way of example. If you are dependent in bathing, that looks like this. You're wheeled into the bathroom or the shower room. You are helped to transfer into a shower seat. You are, you get wet with a shower massager, and the person washes every part of you, including your hair, and you just sit there and you're being bathed. That's a dependent ADL in bathing. And that is usually nursing home level of care. If you are dependent, that's nursing home. Now we'll take that same example of bathing, and we will go with a walker and walk into the bathroom, and you're seated in the shower room and you're handed a bar of soap, and you can cover your front, you can cover your ears, and you kind of get to your hair, but maybe not the back of your head, and the caregiver provides the rest of it. That's assistance in bathing. That's assisted living. So then if you went down the line with ADLs, dressing, you need someone to actually put on the shoe, put the Velcro, put the whole sock on. You can't do anything. You can't pull up your pants. You can't, dependent. So if you're thinking, does my mom or do I or does my spouse need assisted living, or do they need nursing home care? And then I'll complicate it even more and say in Florida and some other states, they've added a special license for assisted living. In Florida, it's called extended congregate care. I don't know what the other 49 states, whether they even have this licensure or not, but I guess some of them do. I think some of them do, which allows for dependence in 2 ADLs. So in Florida, you can be dependent if a facility has a special license to allow you to receive dependent care.
And can you repeat what that license is called again, at least in Florida?
It's called Extended Congregate Care, ECC.
Thank you. I have heard it termed in the rehab world, independent, minimal assist, which they get 25% assist for care, moderate assistance, around 50%, maximum assistance, 75% is done by the caregiver, and then dependent. Does that sound about what you're describing?
Yeah.
As another way of people understanding it?
Yeah, that's a great reminder. And then you can kind of see where some facilities have point systems, and they'll measure and assign points for a bath and points for dressing and points for how much help you need at the dining room table. And then if you exceed their points, then you move to the nursing home. And it's subjective. It is subjective. Now, assisted livings, if they were guilty of anything, you know, it would be providing more care than maybe they're licensed to provide. They don't want to lose the bed. They don't want to lose. So a lot of times people get worried that they're going to get kicked out of assisted living too early. And, you know, maybe that happens. And I think that does happen, but they like to hang on to their residents. Now, let me give you the trump card for the ADL assisted living requirement, the trump card. If you are on hospice, you can stay in assisted living. Now, what I've seen is if you're dying, you can stay where you are. What happens is an assisted living facility hires caregivers based on the state regulations. And if they have someone in their facility that's on hospice that's bedridden, they might not have the staff to provide all the care that that person needs. So if you want your loved one to stay in assisted living on hospice, you might have to fund or hire extra caregivers to provide the care that's needed, because the facility isn't obligated to provide that dependent care. They just can't kick you out.
So can we talk a little bit about the different types of care in the community? So, and I know some states call them different things, but we have like independent living. And so what's different but from an independent living community versus staying at home? So we'll talk about the minimal amount of assistance.
So independent living communities, and I will say independent living communities, not continuing care retirement communities. We're talking about independent living rental communities. The services that you can normally expect to find on these campuses are a certain number of meals per day, emergency call bell in each of the rooms, the bathroom, the living room, and in the kitchen, bedroom, 24-hour security, transportation, maintenance, housekeeping, activities. Usually in independent living, rental communities, no medical care is provided. You have to be independent. I think there was a situation out in California, an independent, and some medical event happened and the family got mad at the independent living facility. And, you know, there was some judgment issues in my mind, but legally, they're not required to manage you medically. It's independent only. So what's the difference between an independent living community and staying at home? Well, I could argue both sides of the case, and it's personal preference. You know, there's some peace of mind for people if there's 24-hour security. There's the relief that I don't have to cook if I don't want to. I don't have to worry about maintenance. I don't have to worry about housekeeping. It's a little less worry. It might be more expensive, but I don't have the ongoing payments for yard care and, you know, and the hassle of, or the worry rather, of something happening to your home that you'll have to deal with that you don't have to deal with anymore. But it's different from an apartment because it's retirement independent living. So they know that they have to have a way to make sure that you're okay on a 24-hour basis. You know, you don't show up for lunch or you don't call in. Sometimes they have a system where if they haven't heard from you by noon, they'll go into your apartment and check on you and see if you're still alive, you know. That's what you get in independent living.
So the term aging in place, we hear quite a bit. So can you discuss what that even means for someone?
Yeah.
That's so like nebulous. Like, what does that mean?
I know aging in place. What does that mean? So Everybody that falls in the bell curve of the fragile years, you're in the fragile years, you're going to need assisted living, whether you get it at home or whether you actually move into an assisted living community. What aging in place means to me is, the battle cry of everybody I've ever worked with is I want to stay home for as long as possible. And to do that, I need support to stay here for as long as possible, if not forever. And so what that means then is physically, does the home support wheelchair, walker? Is it accessible? Physically, can you get in and out of the shower? You have grab bars installed. Is the sink too high, too low? How's the toilet seat? It's one of those old ones where it's so low you can't get up. Are there any renovations that you need to do physically to the home? Do you need help cooking? The other term that is out there that I don't use a lot is that IADLs, and that's the instruments of activities of daily living, which is all the household chores, laundry, bed making, yard work, heavy chores. Do you need help with that? And are you financially able to pay for it? So if you want to stay at home, aging in place means, have I looked at my budget? Have I looked at what's available? Have I looked at what I probably will need? And can I pay for it? And if not forever, how long can I pay for it? How long can I stay in my home on the budget that I've set up for myself? Whatever that budget is it $2,000 a month? Is it $5,000 a month? Is it $10,000 a month? And what do caregivers cost now? And right now we've seen a 30% increase in the hourly caregiver rate across the country. And so that cost is not being borne by home care companies, that's being borne by the client. So we've had clients that have gone from in Orlando, $24 an hour to now it's $30 an hour. And you have to buy it in 4-hour increments, 4-hour minimum. So you think 4 hours a day, $120 a day, you're already up at $3,500 to $4,000 a month. So in aging in place, and the other thought I'll throw your way is, I've had families say, my mom wants to stay at home and she doesn't have any money, but they reverse mortgage the house. So, age in place means, to me, having the physical and the medical and the financial support that you need to stay at home. When I was a facility administrator, if I said aging in place, it would mean you can stay here for the rest of your life. We're never going to kick you out. Aging in place. And when a facility says that, the questions as a consumer that I would want you all to be asking is, what does that mean specifically? Do I have to hire an agency? Do I have to hire a hospice company? Do I sign a waiver that you're not going to throw me into the hospital and then refuse to take me back? Is there a contract that I sign? When you say aging in place, are you allowed to make me hire 24-hour care for me to be able to stay here? You can say age in place, but if I can't afford $15,000 a month for care, then in truth, I might be allowed to age in place, but I can't financially afford to age in place. And you can tell by the way I'm talking that aging in place can mean different things to different people, professionals, and then in different states.
I'm so glad that you brought up those points and things to ask, because they don't offer all of that information up front. So it's good to, and you don't know what you don't know to ask. So
right, that's right. And there's a really good question here. Can you hire your own caregivers and still live in independent living? In my experience in independent living, you can hire caregivers and they can work 24/7. So I've seen it, and I look at the contract just to make sure. That's what I would look at the contract they're proposing to see if that's prohibited in any way, or look at the reasons where they could discharge you without your consent. And that would happen if they felt like you were a danger to yourself or somebody else. Now, Where it gets interesting, the question about caregivers and independent living, is when you are living in the continuing care retirement community facility. And a CCRC, continuing care retirement community, is a known product, CCRC. And it's really an insurance product. And so it's an entrance fee that you pay. You either pay an entrance fee that's non-refundable or it amortizes over 4 years. Usually after 4 years, you don't get any money back, or you pay an entrance fee with what's called a guaranteed refund option, meaning you pay a higher entrance fee with the right to get a percentage, usually 75 to 90% back to your estate when you die. In the independent living area of a CCRC, having caregivers in the independent living apartments can be prohibited. And I'm going to let you digest that a minute. Not always, and I've seen enough that I like to have the question answered. And I'll put myself in a client's shoes. She moved into independent living in a CCRC. And the woman next to her became wheelchair bound, got very, very sick, and she had caregivers coming in and out of her apartment, and she was furious. I didn't move into independent living to live next to sick people. She needs to move. And then the salespeople that are touring these young people wanting to move into continuing care look on the independent living floor. If they see sick people in independent living, it might prevent someone that's younger that wants to move in from moving in because they don't want to be around sick people. I've been in other continuing care retirement communities where people have had 24-hour care and residents just get used to it. So it would be wise. And then I was just in a continuing care retirement community where if you were a couple moving into independent living, but one of you had a memory impairment, the one with the memory impairment wasn't allowed to live in independent living. The one with the memory impairment had to live in assisted living. So you want to be sure, if you're evaluating whether to move into a continuing care retirement community, what the rules are and how much control the management has over what level of living you are at, how much care can you receive in the home, and how much aging in place happens in their community. So what goes for an independent living rental community can be very, very different in the continuing care retirement community arena. We have a question that talks about long-term care insurance. So let me touch on that a minute. Long-term care insurance pays usually a daily rate for nursing home reimbursement, and then a daily rate for assisted living and a daily rate for home care. Most of the time, the highest daily rate is paid for nursing home care, and then a percentage lower is paid for assisted living care. So by example, I would say they pay $400 a day for nursing home care. 50% of that is if you're in assisted living. So $200 a day for assisted living. And then $200 a day for home care or caregiving. So long-term care insurance doesn't pay for independent living, but pays for nursing home care, assisted living care, and caregiver services provided, usually, not always, by a home care agency that's licensed in the state in which you reside.
So in the continuing care communities, you mentioned this already, assisted living, memory care, and then nursing facilities. So, and I do want to break down what each of those mean and what kinds of care they have. But in a CCRC, they do offer the different levels. So you kind of alluded to that when you said somebody that is married to somebody that might have a memory disorder may be forced to move into the assisted living facility, but the spouse could stay in independent living. So they have independent living, assisted living, and nursing. Can you cover a little bit about that? And then we'll go to each individual level of care and talk about those, what that means.
Yeah, so in a CCRC on campus, they're required to have independent living, assisted living, skilled nursing, security, maintenance, housekeeping, activities, transportation, and medical or nursing support on campus, certain number of hours per day. And the entrance fee gives them on average a 20% discount or more, depending on your contract, for assisted living services and skilled nursing services. It also frequently gives you a number of free days in their nursing home. So if you had a broken hip and you recovered, you still weren't ready to go back home, you might get 20 days free care in the healthcare center.
But don't you get meet qualifications under Medicare in a skilled facility if you come from a hospital and you need rehab?
Yep, and what you're implying with your question is very, very accurate. I rarely saw people use free days in the healthcare center. They just wanted to get back home. You know what I mean? Like they didn't want to stay any longer than they needed to. So, but it's available and it's a nice thing to know that you have. But yeah, you unless you run an advantage plan and you didn't get that much rehab care covered.
And that's a whole nother conversation.
That's a whole other conversation. Yes. Absolutely. So earlier, when I was talking about the long-term care insurance, I was only talking about care services. It's really, really wise to make sure that you have an updated long-term care insurance policy. A lot of times I meet with people and they have the policy from when they bought it and it's outdated. So you got to order an updated policy explanation sheet and coverage eligibility. But medical equipment, caregiver training, family training, some care management, there's more that long-term care insurance plans cover. The bulk of it is for care needs.
And there was a question about the long-term care insurance paying for assisted living care if it's the partner that qualifies for assisted living, not the policy holder. They're not going to pay for that, right? They're only going to pay for the person who actually is on the policy and is needing the services.
That's right. That's right.
All right. So assisted living, what exactly is that in terms of level of care? Like you talked about they can't do dependent care, but how much care can they provide? And you did reference the potential of hiring assistants to supplement that. And some have, like you said, the additional rider that they can do maybe up to 2 ADL. So I don't want to muddy this too much, but can you break that down a little bit so people understand exactly what assisted living is compared to a skilled nursing facility? We'll get into that next, but like what exactly is an ALF?
So an assisted living facility, it's a licensed facility and they're all different sizes. You can have an assisted living that's 5 or 6 beds, a home in a neighborhood that's licensed by the state. Most facilities have a room and board rate, $4,000 a month, $4,500 a month, that entry level rate. And then you pay for levels of care based on what you need. And I'm saying normally. In the old days, it was a flat rate, no levels of care. sometimes you'll find a facility that's a flat rate. That's not the norm. I would say maybe 10% of the facilities are a monthly charge and it's all inclusive. Usually it's a flat rate, and then you buy up for levels of care, and there can be upwards of 7 levels of care. And it runs around $200 to $250 per level. So say, for instance, you start at $4,000 a month and you buy 2 levels of care, $250 a level, you're at $4,500 a month. And so the facility will evaluate what care you need and then tell you what level you're at. Medication is usually entry level, and that's about $500 a month. Most people who move into assisted living, most, not all, don't manage their own medicine. They need a nurse to give it to them, or they need a med tech to give it to them. I have had on occasion people do their own medicine. So, you know, it's a question that you can ask. And if you're able to manage your own medicine and you're living in assisted living, maybe you can save $500 a month and do it yourself. So then you buy up, and then over time, as you get older and need more care, you add a level up until you've hit the maximum. And the maximum is generally for those with a memory impairment. That's the highest level of care. The most expensive assisted living care is memory care in assisted living. So it can be small, medium, large. You can be living in a studio apartment. You can have a 2-bedroom, 2-bath deluxe with a water view. You can have a 1-bedroom with a den. Lots of physical configurations with you generally a move-in fee to start. You pay a $2,500, $3,000, $5,000 move-in fee. That's an administrative fee. It's non-refundable. And then you pay by the month, and you give a 30-day notice when you want to move out. So it's not a permanent long-term lease that you're entering.
And if somebody has a change in their level of care, then that might be the case. So you mentioned that the facility will evaluate somebody and assign, you know, what level they might need in the facility. So how would someone know that they maybe have entered to the phase where they need a nursing facility versus assisted living facility? Can you break that down into like understandable pieces? Like, is it, if you can't do 3 like ADLs, you're definitely ready for nursing facility? And I do want to go down the road of discussion. What is the difference between nursing facility and skilled nursing facility? Because those things are used interchangeably also. And Medicare does pay for some skilled nursing, but people get that very confused and think that they're going to pay for all of it. So
that's right. That's right. So ideally, and I call them the in-betweeners. You know, that there's always a stage at which the person in assisted living needs more care and they're not getting it. They want to live in where they are. They want to stay in assisted living, but they need more care and they're not getting it. And they're not really ready to live in a hospital-like setting, which is more like a nursing home or nursing facility. Ideally, the communication between the caregivers and the family is ongoing. So everybody is kind of like, you know, she's declining. It's getting, it might be a sudden decline because of hospitalization, going to a rehab facility and really going back is not an option. But if the care, and then one specific is, can the person stand independently, and can they independently transfer from bed to a chair? It's a thing you can look for. If that can't be done by the person, usually they belong in a nursing home. The other tool I like to think about is, can they get out of the building on their own in case of an emergency? Can they get, you know, if somebody puts them in a wheelchair, can they get out? If they can't, might be time to have a conversation about needing a higher level of care. If they are dependent on the call bell, and I've seen this a lot, where they're living in assisted living and they hit that call bell and that nurse didn't get to me for 2 hours or an hour, a long time. If you are call bell dependent, you need to live in a nursing home. Because assisted living, that call bell is for an emergency. And I've had clients over the years, they just think the call bell's for when they need help, and assisted living is not staffed for that. You might have 15 residents that you're going to help get ready for the day. And if you have 15 residents that need to be hitting that call bell, you need to go to the nursing home where the ratio is lower staff to patient ratio.
Oh, you made a good comment, staffing. So obviously in a nursing facility, a skilled nursing facility, we're dealing with nurses. What is the criteria for staffing in assisted living? Like, how much difference is there?
So I'm going to go out on a limb here and say that the assisted living industry is in a crisis. And by that, I mean they sell a medical model of care and they provide a social model of care. And I know this is recorded, and I know that I'll catch some heat for this. And I've argued with assisted living communities locally. But the staffing in assisted living most of the time does not have a registered nurse or a licensed practical nurse on board 24 hours a day. Very few of them will have a nurse 8 hours a day, or they have one nurse for 200 people. And the staff that is giving the medications in assisted living are usually med techs. And med techs get 4 to 6 hours of training, period. Now, I don't mean to say assisted living facilities are bad, they're wrong. I don't mean that at all. I just mean that your expectations, if you have a medically complex, and I'm talking to Parkinson's, so that is inherently medically complex. You want to make sure that they have a nurse that understands the importance of the timing of your medication. You are, or you do it yourself. You know, you manage your expectations to where he's got to live in assisted living. That the assisted living is, you know, geographically close to me. That's more important than a nurse. The facility that has a nurse is 30 minutes away. So I'm going to pick the facility that's closer, but I'm going to give that medication to him 2 times a day, or to her 2 times a day. So the staffing is more during the day, 1 to 15, one caregiver to 15 people, maybe it's 20. You know, they're zipping in, they're helping them with the shoes, they're getting them down the hall. And they have a nurse practitioner that works, or a physician's assistant that works under a doctor, that come into the building once a week.
So I'm glad that you're talking about that and managing the expectations, because I think a lot of times people they don't realize what the staffing is and enter into this idea of something they're going to get, and it's not. So let's talk a little bit about nursing home, nursing facility, skilled nursing, and what those mean, which ones Medicare pays for, which requires typically a hospitalization if it's a Medicare paid stay in a nursing facility, versus being able to just move into one for home. What does all that mean?
So like we did levels of care earlier, I will give you the definition of a skilled nursing facility. Skilled by definition means The facility provides services, skilled services, which are services provided by a person with a license. So a physical therapist has a license. A nurse has a license. An RN has a license. An LVN or an LPN has a license. Occupational therapy, respiratory therapy. Skilled nursing facility is a facility that provides services by skilled professionals. Skilled nursing facility, rehab facility, and nursing home are synonyms. It's all the same thing. And you'll hear the word rehab facility. Oh no, it's not a nursing home, it's a rehab facility. A skilled nursing facility is called a nursing home, is called a rehab facility. By definition, a rehab bed in a skilled nursing facility is a short-term stay. Short-term bed versus long-term bed. Now, a nursing home or skilled nursing facility, a lot of them are 120 beds in size. Some are 140, 150. You can get some of the bigger ones, 220. Every once in a while, you'll see these little ones. We've got 3 little ones in Florida. One has 48 beds, the other has 39 beds, and they're not the norm. Usually we'll just use 120 beds. Half of the beds are rehab or short-term beds. So 60 rehab. And the other side of the building is the long-term side. So you have the rehab side and the long-term side of a skilled nursing facility. One side's called the rehab unit and the other is the long-term unit. The rehab unit are the Medicare covered stays. Medicare pays for rehab. And rehab is usually physical and occupational therapy and speech therapy. And Medicare pays for up to 100 days, not 100 days, up to 100 days. The average number of weeks that you get under Medicare is 4 to 6 weeks. The people that get 100 days are the massive strokes, a really bad wound. Those get the 100 days. Unless, and here I will give you some common language, and then I'll give you the trump card. So the language in Medicare, although it's not written anywhere, is, and you'll hear this, Medicare and your supplemental insurance will continue to pay as long as you're making improvement. So this week you're walking 50 feet, the next week you're walking 75 feet, the next week you're walking 150. Medicare continues to pay. Once you've plateaued and you've reached your highest level of functioning, Medicare will stop paying. That's not written anywhere in the Medicare rules. There was a woman from Delaware who sued Medicare and won. I love this. I love a bulldog. So what she did was she needed the services of a skilled person to maintain her level of function. And if you want to look it up, it's Jimmo versus Sibelia. And if you go to the MedicareAdvocate.org website, you can read about it. And you can appeal a discharge if the physical therapist and occupational therapy team says you've hit your highest level of function, but you're diabetic and you're getting insulin injections and you are at risk for a wound and you need that week-to-week RN license to maintain your level of function. You can appeal the discharge and get more time. How much more time? As long as you need the services of a skilled professional. And it's Jimmo, Jimmo, and I think the Sibelia is Sebelia.
And you said the website they could also go on is Medicare Advocate?
Advocacy.org.
Okay.
Yeah, that's a great little website. So, but for planning purposes, when your loved one goes into the rehab unit, you want to really know the therapy staff and be talking to them week to week about how much time do you think, I'm not going to hold you to it, but how much time do you think we're going to get here? And they'll tell you, well, a couple weeks, 3 weeks. Don't wait, because if you wait, you're going to get like 3 days notice. They meet once a week, they review their caseload, and they determine who's going off Medicare that week. It's usually on a Monday or a Tuesday, so you get notice on Monday or Tuesday that the last day is Friday. But if you're already engaged with the staff and you know, you can plan, plan for 4 to 6 weeks, kind of hear from the therapist that that's what they're thinking also. Then you can have your discharge plan ready to be implemented and you're not caught by surprise with 3 days of, oh my gosh, what am I going to do? Now, if the rehab, you're as good as you're going to get and you've appealed and you can't afford the care that you're going to need to go back home or back to assisted living and you need to stay there, you may have the ability to move into their long-term side. If you think that that is a potential, I would be talking to the facility all along the way that if it doesn't work out, we really want to stay, and just lobby that effort. That I hate to talk about nursing homes as a business, but in a 120 bed nursing home, you probably have 2 deaths and 3 discharges a month. So 5 vacant beds come up every month. You want to be on their radar. If you really like the facility and you want to stay in there long term, let them know and lobby for that week to week. And let me publicly apologize for not saying speech therapy. I love the work of speech therapists. It's like the last thing, physical, occupational, and speech, and I just didn't get to it. So I love speech therapy. They are licensed.
You just didn't get into it because I remember you saying it.
Okay. They do wonderful work with clients. So you get where I'm, and then also if your loved one's at the hospital and you're looking for a bed and they're getting a short-term bed for you and you think this is really long-term, you're going to want to think that through before you're discharged. You might not want to go to one place short-term and then try to find a long-term bed somewhere else. Maybe you want to go to a place that has long-term and they'll tell you up front, yeah, they can stay here. So it's important to understand the concept of short-term bed and a long-term bed as it relates to discharge from the hospital.
And another important point to make with this is that, Medicare is only going to pay for so long, like you said. And if they enter into the long-term side of care, that's an out-of-pocket expense. So what do people do unless they have long-term care insurance? If they don't have long-term care insurance and they cannot afford the fees that is associated with long-term care nursing facility placement, what are the options for them and how do they activate those options? At what point?
All right, so I'm going to say this to you and I'm going to say it loud and I'm going to say it really clear. Do this now. What I'm about to say, do this now. Don't wait, don't wait, don't wait. Understand the world of public benefits now so that you have choices down the road when you need it. And I'll talk about this gal whose mother lived at home and her mother had longevity on her side. Her mother lived till she was 99. I met with him when she was in her early 70s. She had $350,000 in her house. And the lawyer, and I'm practicing law without a license, but I'll throw out what the lawyer said, take the 350 and move it into a trust right now. So I think the daughter moved it into her name. She didn't even put it in a trust. She put it in her name. And about 8 years later, we had to file for Medicaid and we got it. And so she got in-home care at her home. and the daughter got to use the money that she'd moved over. She'd used it to spend on her mother over the years. She used that money that she moved over to help supplement what the state wasn't able to provide in terms of caregiver in the home. So my point isn't hide your money from the government. My point isn't cheating from the government. My point is not any of that, except it is to say that know what the public benefits are, and they are Medicaid, veterans benefits. Those are your two public benefit programs that you can pull from. In the nursing home, it's one or the other. You either get Medicaid or VA because they're both federal benefits. In assisted living, you can actually use both benefits, the VA and Medicaid, in most assisted living communities across the country, because the states don't always pay full rate in assisted living. Assisted living is the biggest emergency in the Medicaid world, in my viewpoint. And when I say do it now, I want you to understand, if you have a house, is it exempt from Medicaid? If you have long-term care insurance, how does that work with your income? If you have life insurance that has cash value, you're going to have to withdraw that money. If your income's, $4,000 a month and you're over the income limit, can you still get Medicaid? If I have IRAs, and I'll tell you, in Florida, IRA is an exempt asset in Florida. I had a client that $1 million, and I'll repeat that, $1 million in IRAs, and we got her Medicaid that next month. Because in Medicaid's eyes, she didn't have any money, because IRAs are exempt as an asset as long as you're getting income. So for the state, they were like, well, we're going to get, her income was $5,000 a month. So they were only funding, $3,000 a month to help pay for her care. She got to keep that $1 million. I don't know about California law or any other state law, but I'll go back to my original statement is know your state, get with a care manager, get with an elder attorney, and get educated as to what the benefits program looks like, and what you would need to do, if anything, to qualify. I had a lady call me last week. She had $4 million and she was 90. She didn't know she wanted to file for Medicaid for her husband. Well, she didn't need it, but we walked through it. I did a consultation. But what I worry about are the people with, a couple 100,000, half a million, and you're married and you own a home. And right now, nursing homes are running $10,000 to $12,000 a month in Florida. They're more like 18 in other states in the union. So, and you need to understand that there is a look back period. And for Medicaid, it's a 5-year look back period. And what that means is the federal government has the right to look at your documents to see if you did anything illegally with your money. It doesn't mean that you can't do it. There are legally allowable transfers of assets. So you can transfer assets, you just have to do it legally. But the federal government has the ability, like if you live in New Jersey and you file for New Jersey Medicaid, you have to provide 5 years of bank statements, period, end of story. I don't know about other stuff. Florida, it's 3 months. And then if they get ideas that you've done something fishy with your money, they'll ask for more. But they can legally ask for 5 years of bank statements and financial information. And the question is asked, have you transferred any money in the last 5 years? And if you answer no, and you did, you will be ineligible for Medicaid benefits, in addition to being brought up on fraudulently filing for Medicaid benefits.
So we're at the top of the hour. However, one last question I think is a good one is if someone is not able to afford an attorney, and a lot of these like particulars for your state, really the best thing to do is to talk to an expert in your state. But if someone can't afford an attorney, who do they reach out to if they're wanting some guidance?
Here's what I would do. So aginglifecare.org is the organization that houses care managers across the country. And you put in the zip code and care managers will pop up. And then you're going to look in there. They usually list the services that they're an expert in. And entitlements is something, if you see entitlements, they understand the Medicaid and the veterans world. If you're in Florida, o'rourkeandassociates.com. We know Medicaid and VA. We know VA nationally. If you want to know about VA benefits, o'rourkeandassociates.com. We can absolutely help you understand that benefit. So care managers is a really good starting point, and then they know all the elder lawyers, and they know which elder lawyers can help without price gouging. You know, there's some lawyers that'll charge you, you know, $20,000, and there's other lawyers that it's, you know, within customary normal, you know, so you want to, care managers know the people that are in it. Everybody makes a profit, but they're not price gouging. But you want an attorney that is worked with the Medicaid and the veterans benefits.
Awesome. Well, Amy, thank you. I know that we didn't get to cover the whole hospice aspect to the degree that we'd like to, but you gave us such an amazing overview of this very confusing web of long-term care placements and acronyms and all of that, and what a level of care means. So thank you for making that easy to understand. And just thanks to everyone for joining us and listening. It will be recorded, and I would say give it a day or so and it'll be up on the website, because I know we threw a ton of information at you. So you may want to go back and review it, listen to it again, take some notes. You can always pause it, rewind it if you need to when it's recorded. This is the beauty of recording. You may also want to save your chat, because we did put up what some of the terms mean. There's the websites that we've referenced. So if you want to know how to save your chat, if you go over to the text box where you're writing your chats to us, the three little buttons over at the far right corner, if you pop the more up, there's the option at the very top that says save chat, and that will save to your device. That way you can go back and review that as well. So as our usual way of thanking our wonderful speakers, if everyone would be willing to thank Amy with a wave of gratitude, we'll just say thank you so much for joining us again and sharing your amazing knowledge. So thank you, Amy. And
Pleasure
thank
to
you
be
to everybody who joined us today. Hope you have a wonderful day.